sudden, usually very unilateral pain, and it's very brief and it's stabbing in nature in one of the divisions of the fifth nerve. And where it happens, various studies have various statistics. I just picked up this one. It's usually in the elderly age group. You rarely see children having trigeminal neuralgia or young adults having trigeminal neuralgia. It seems to come when the vessels become more atherosclerotic and stiff. Maybe that's when they start hammering the adjacent nerve. As long as they're elastic and they are fine, they don't need to disturb the nerve. And it's very paroxysmal. And recurrent episodes of pain with intermittent periods of remission means you may have bouts of trigeminal neuralgia, patients will say, and then for some time, months together, they don't have a problem. Then again, they start getting it. So we don't know whether it's positional or it is something to do with healing of the nerve that happens intermittently and then again goes back. Problem. But always localized to the trigeminal nerve. And most often it is in the maxillary and mandibular division. One side may be dominant over the other. So to highlight the quality, it's paroxysmal attacks. That means it's infrequent and comes suddenly, electric shock-like quality. And patient will be grimacing. It's like coming suddenly, so they take it up with a jolt. It lasts very short duration. It never lasts longer. But as the pain increases and keeps on going forward, it can become atypical. Then they may have constant pain always during that region. But in the beginning, it's always pain-free period in between. And they are totally symptom-free between attacks. Unlike some other pathological pain, if it is referred in the face regions, they may have pain always in between attacks. Now, this trigger zone is very classical of trigeminal neuralgia. So they may have some area in the face or inside the cheek or in the distribution of the fifth nerve, which if anything touches, like mechanical touch, will trigger the pain. So it could be anything. It could just be a whiff of air. If you are traveling in a bus or in a two-wheeler and just the air hits them on the face, they will have pain. So they tend to cover their face when they travel, but they can't touch the face. If they touch the face, then you get the pain. So they'll just be holding their face or covering their face partially so that nothing touches, even wind touches on it. Eating, chewing, even talking, sometimes when they speak, this area moves so it triggers the pain. So they'll find it extremely difficult. It is one of the most probably disabling symptoms because pain is there, plus they can't do the normal activity. So what is the differential diagnosis? So what all when the patient complains of this kind of pain, what all it can be mistaken for. So if it is very stabbing, if it is very paroxysmal, very short, lightning kind of pain, it's very easy for us to diagnose with the trigger zone. It's very easy. But if it becomes atypical, as the pain progresses, the symptom-free period keeps reducing and the pain becomes more and more lasting. Then, of course, it can be confused with dental pain, sinus pain. So most of these patients usually land up with dentists. And once the dentist sees inside and if you examine the oral hygiene, most of them might have definitely a tooth that could be responsible for the problem. So they usually land up getting one or two teeth extracted. And after that, still the pain doesn't subside. Then they start moving from one physician to another, or the dentist himself says, look, this could be trigeminal neuralgia, you better meet a neurologist, or if you start treating with medication, it doesn't subside, then it gets referred to a neurologist or neurosurgeon. So one is awareness. So if you are aware that this pain, the nature of the pain, see there is no imaging to diagnose trigeminal neuralgia. Just a good history taking, finding out the characteristics of the pain. Of course you need to do a sinus examination, dental, oral examination to make sure atypical facial pains may be mistaken. And that could be post-herpetic neuropathy, temporomandibular joint dysfunction, trigeminal neuropathy or even facial neuralgia. All these only in the later stages of trigeminal neuralgia or a atypical type of trigeminal neuralgic pain. I would say probably 70 to 80% of trigeminal neuralgias are very difficult. The 20-30% we always land in trouble. Those are the patients in which one has to be suspicious. You find a dental problem, you treat it. Even then if the pain doesn't go away, then you can always keep the atypical trigeminal pain in mind. So that way it will be helpful. Now what causes the trigeminal neuralgia? So as I already explained to you, we just go over the anatomy, you know the details of it. Now there are three divisions and they supply the entire face and the vertex almost up to the back of the head. It's all supplied by the fifth nerve. It's sensory in nature predominantly. Of course there is a motor component, we are not interested in that. So to simplify it, we have three branches, the visual V1 division, the V2 division, and the V3 division. So the pain usually is in the V2 and V3 division, the mandibular and the maxillary division. And the trigger zones usually are in one of these two areas. But it's very important to ask whether it goes above the eyebrow. Does the pain go above the eyebrow? If the pain is coming above the eyebrow, that means V1 division is involved. I will tell you why this is important to find out if V1 division is involved, because that's going to determine what kind of intervention we can offer to the patient. So usually it is in the V2 and V3 divisions, and if you take the anatomy right into the brain, you know that these three nerves come out from the ganglion, the Jaserian ganglion, that is the trigeminal ganglion, and then there is this trigeminal nerve loop, and then it comes out of the pons. So you have the pontine nucleus, trigeminal nucleus that is present inside. So the pathology right from the ganglion to the brainstem, anything which compresses the nerve along this segment, or involves nucleus of the brainstem, like in multiple sclerosis, demyelinating illness, can produce this problem. So think of it as a nerve which is like an insulated wire with a myelin cover. If the insulation is lost for some reason, either demyelination or because of recurrent trauma caused by the arterial pulsation, or caused by a tumor compressing on this nerve, makes the insulation go away. So two nerve fibers that can now short circuit, they can cross talk. So the pain fibers and the sensory fibers can intermingle, and what is called epileptic transmission happens. It's like an epileptic phenomenon. So even without a touch, or touch can be interpreted as pain because those fibers are interconnected because of lack of myelination. So that possibly is the basic pathophysiology. So you can see that the normal vessels are present around that structure, and just so as a cartoon representation, we would take it further. I'll show you with the loop. So various disorders like the vascular compression itself, which is the cause of so-called idiopathic trigeminal neuralgia, or any tumors in that region, or a demyelination can produce the symptom. Now, multiple sclerosis, usually it produces bilateral. Whenever it is brainstem central, you can see it bilateral. Unilateral pain, usually not because of demyelination, because of multiple sclerosis. So if somebody comes with bilateral trigeminal neuralgia, you should get alerted. This could be a brainstem issue and could be a multiple sclerosis. So some scans quickly show you this acoustic tumor, but if it is large enough to come up to the exit of the fifth nerve right there, it can irritate in that segment and produce the pain. And the segment is important. It is the root entry zone where the junction of the peripheral and central myelin combine, and this area may be very vulnerable to any kind of compression and demyelination that can happen. This is an epidermoid. This is one of the commonest tumors that presents with trigeminal neuralgia, because this tumor, epidermoid, is deflating squamous epithelium, which sometimes remain as cell rest in the embryonal period, beyond which in adulthood they go on accumulating the squamous epithelium, and that produces compression, immediate structure. It does not produce neurological deficits, but it can produce irritative symptoms. So if it is in the cortex, patient presents seizures. If it is in the next to sensory nerves, it produces irritation and produces sensory symptoms. So if it is next to the trigeminal nerve in this region, it can irritate and produce pain. So one of the commonest tumors, if anyone asks you what is the commonest tumor you can have with trigeminal neuralgia, maybe epidermoid is the one which is present with trigeminal neuralgia, unlike a schwannoma or a meningioma, even if it is coming from the other trigeminal nerve, because of its irritative nature. And the fifth nerve tumor itself, this is the fifth nerve on the normal side. This is the shaded area of a tumor right over the nerve. Usually, if you have a tumor, it destroys the nerve itself or compresses the nerve beyond its function. So you may have a full hyposthesia, deficit of the nerve. So if you examine the patient of trigeminal neuralgia, if he allows you to touch his face, you will see that he does not have any deficit. If he has a deficit, if he has a motor deficit of fifth nerve or a sensory deficit, he complains of numbness on the face, it is definitely not idiopathic trigeminal neuralgia. There has to be a cause for the trigeminal nerve irritation. Could be a tumor or something resting there. You should immediately ask for imaging. So this is the vascular loop which I was referring to. If there is a loop which is crossing the nerve or touching the nerve directly, and if this loop happens to become non-elastic because of, say, atherosclerotic disease, and it starts with every pulsation, it will act like a hammer on the nerve. So the nerve starts the compression right at the root entry zone, you can never predict. But studies now looking back on images whom we have operated have shown that the MRI can pick up with fair certainty that it is correlated very well. The false positives are very low. Of course, that depends on the experience of the radiologist who's reporting. So what happens if a patient has trigeminal neuralgia? So this is what I had explained to you initially. The periods of exacerbation are limited and periods of remissions are longer. As time passes, as the disease progresses, later in the course, probably they have continuous exacerbated stage and the periods of remission are far less. So we need to break the cycle somewhere and give them relief so that they don't enter from here to there. That becomes very difficult to treat. So what can be done about it? So how do we go about treating a patient if your family is satisfied that yes, this is trigeminal neuralgia? You are not sure if you do an MRI, you will get a diagnosis because it will only tell you if there is a tumor or not. So if it is a tumor, you know, yes, probably this is medication. You can take the patient up for reference to the neurology surgeon to do the needle. But if you are in doubt, start the patient on medication for trigeminal neuralgia. If there is a response, that itself is a good indicator that yes, this is trigeminal neuralgia. Because these are not medications given for pain. These are neuralgic medications given for neuralgia. They block nerve transmission. If you see the list here, the primary medicines that I use have been anti-epileptics. So they interfere with the conduction. The paroxysmal nerve conduction disorder is stabilized by carbamazepine. So if you give carbamazepine or oxcarbamazepine, which is less toxic, more tolerated, you will find that patient has good relief. At a very low dose, if you start on 200 milligrams, just twice a day or thrice a day, they will say that my pain is gone. At least the frequency goes away. If that even happens, you are fairly certain that this is trigeminal neuralgia. Now newer drugs have come in like gabapentin, pregabalin. Yes, the carbamazepine side effects are quite a bit, so I'll come to that. So you have to start with the initial small doses. The good thing about carbamazepine is the tolerance level is very high. You can go up to 2,400 milligrams per day. So that is equivalent to almost 600, 800 mg per dose to 3 divided doses. You can have problems with blood dysplasia. So you have to check. There can be dermatological side effects. There can be blood counts that can go down. Thankfully, this happens in less than 10-15% of the patients. So you can say 80% of your patients will be fine. Tolerance is a problem with carbamazepine. Most patients who have carbamazepine will say they are feeling dizzy, but it settles down within 3-4 days. And if you start on a low dose and build up, suppose you want to be safe, these are elderly patients, so you want to start on 100 milligrams, go for BD 100 mg, set the night dose. Now you get the entire range. Varieties 100, 200, 300, up to 800. Yeah, 100. So you can start with 100 twice a day, then step up the night dose to 200, then bring the morning dose to 200 over 3 days or 2 days. Then the tolerance will be very good. The good thing about oxcarbamazepine is it takes away this dizziness and this